you'll get that kind of a pupil reaction with those. So as far as assessment is concerned and the changes that we see, the big thing is to recognize and describe what change is taking place. There's different ways to assess it, and we'll talk about some of those ways. Whether the patient's awake, alert, wakes up easy, whether you have to go in and kick the bed and really work them up to get them awake. Recognizing if that's different, or if there's something changed, and make sure that we report that. That's the more important part than being able to say, well, I think the patient was somnolent, now they're attended to a certain degree. I'm not so much concerned about that, but just being able to report to the physician a change in something. And the way we do that is by serial examination and trending what our patient's doing. The most common tool we use for that is the Glasgow Coma Scale. I think we're all pretty familiar with that. The thing to remember about it is it's the best response in all three categories. So, sometimes our patients are kind of, maybe there are 3, maybe there are 4 here on this one, but whatever is best for that patient at that time is how you categorize that. So if I walk into a patient's room and they're watching TV, and then after I've talked to them for a couple of minutes, they close their eyes and want to rest for a little bit, I'm still giving them the 4 because they had their eyes open and were looking around. If they're pretty oriented to, they know it's Tuesday, they know that that's their wife, but they can't really remember the date, I'm going to give them a good score because half the time I know. How often do you ask a person what the date is, and then I kind of surreptitiously look at my watch to make sure they're right because I don't know. So you give them the best response in all 3 categories. And then obviously you want to compare their motor strength in all their extremities. Be careful with the noxious stimuli. We always, it's common, we use the sternal rub. In fact, I saw a physician walk in and do that to a patient yesterday, very, very vigorously. It can impair skin integrity, it leaves a mark. So just be careful with that. Better to use a nail bed squeeze or squeeze the trapezius muscle. Or the other one I like to use is push on the supraorbital notch right there, because that hurts like heck. You'll wake somebody up if they're going to wake up with that. And then serial exams. Initially when I get a head injury patient, it doesn't matter what the doc's order is for neuro exams, Q1 hour, Q15 minutes, whatever. I'm kind of just constantly doing that when I'm in the room. You kind of just constantly assess that. If you have a continuous ICP monitor reading, you're watching that. When you're working with the patient, you're seeing what their responses are. And so definitely serial exams are necessary in order to keep up with any changes or to make sure that we recognize those and report them to the surgeon. Some of the other things you might see, AVPU is a term that you might hear from the emergency department. And that's just a quick and dirty assessment tool. Either they're alert, they're verbal, they respond to verbal stimuli, they respond to pain, or they're unresponsive. So you might get a report from somebody in the emergency department that says on the AVPU scale they're a V. Hopefully they will have used the Glasgow Coma Scale. They should, but you may hear that. The National Institutes of Health Stroke Scale, we could spend a couple hours talking about that and how it works, and we probably will later down the road when we start using that more with our stroke program, but it's another tool that we have. Some of the other terms, patients lethargic, obtunded, comatose, whatever, and those mean different things to different people, but it kind of the steps that you'll see as a patient's lethargic, they're obtunded, or they're stuporous, or they're comatose, and those are kind of the steps downward in level of consciousness that you may see. A couple other things that we use to assess patient, the doll's eyes. You know, the normal response is for a patient whose brainstem is intact and they have good innervation to their eyes, is if you fix on a place over there and you turn your head, your eyes are going to still stay there. And so with our patients, they'll test that. They'll roll their head from side to side, and if their eyes stay fixated, their brainstem is relatively intact. But if their eyes just kind of roll around and they don't stay fixated or semi-fixated, then their brainstem, there's no connection between their brainstem and their eyes. So you'll probably see physicians assess that. I don't know if any of our docs here use cold water calorics. Have you seen them do that here, Jordy? Stacy, have you seen them do that?
I've seen Dr. Gans do it a couple times, just kind of as a
last
proof of brain death kind of deal.
Right.
I think he just did it last week.
Did he? Okay. And that's when you usually see it, is one more measure of brain death. And you squirt about 20 cc's of ice water into somebody's ear. And if their brainstem is still relatively intact, their eye will jerk toward that side. If not, if there's no response at all, then again, there's no connection. It's just another tool we use usually for brain death. The Babinski reflex, you rub the bottom of their foot and their toes flare up. And that's abnormal in adults. In babies it's normal, but in adults it's not normal. And so if you see that, it's just another thing to document and make sure, and you know, the physician's going to check it too. But if a patient progresses to where they did not have a positive Babinski and then they do, that's something to make the physician aware of. Okay, so, you know, first 4 hours of your shift, every time you rub the bottom of their foot, their toes clenched, and then all of a sudden you do it again and their toes flare up, then the neurosurgeon needs to know about that. So let's take care of these folks. How we're going to manage them. We want to prevent hypoxia and hypotension, obviously. Treat their ICP, make sure their cerebral perfusion pressure is good. And then we'll talk about some of the surgical pharmacologic interventions and a couple of the other things that we do for them. To prevent hypoxia and hypotension is our number one job. A single episode of hypotension or hypoxia in a patient, in a head injured patient, can increase their morbidity or mortality by over 50%. Just one single episode. And so it's really imperative to do everything that we can to prevent that. Obviously, with multiply injured patients, that takes, it becomes infinitely more complicated on somebody who's bleeding out and has a head injury. But we need to intervene much sooner rather than later. And the best way we can do that to start with is secure their airway and make sure that they're adequately oxygenated. And we'll talk about that again here in a little bit. We want to maintain normal volume. We don't want to overhydrate, don't want to underhydrate, but we want to make sure that they're normal. Dr. Gans has a patient with a ventriculostomy right now downstairs, and one of his specific orders was to maintain CVP 6 to 10. Normal, So we just want to make sure that we keep them that way. And then if we're still having trouble keeping that cerebral perfusion pressure where it needs to be, we may need to use pressors. But again, make sure they're adequately hydrated before we go to that. And normally, what I've seen anyway, is using Neo. Just a straight alpha squeezer. And you're certainly not going to give them something like dopamine that's going to increase their heart rate and increase their metabolic rate. But just an alpha squeezer to make sure that we can keep their cerebral perfusion pressure where it needs to be. Again, ICP and cerebral perfusion pressure, the norms again that we like. Keep their ICP under 12, cerebral perfusion pressure greater than 70. And a little tiny increase in volume can increase intracranial pressure a huge amount. And we'll talk about that here in just a minute. But it goes back to that Monroe-Kelly thing where you have a limited space and it only takes this much to kind of really make the squeeze worse. So here's our ICP. So this is a nice, normal-looking ICP waveform. You have a P1, that's your systolic pressure, and P2 is the brain bulk, and then P3 is the closing of the aortic valve. So this is nice and normal. You got a systolic pressure. It's higher than what the brain volume pressure is here. Now where we start having problems is when we get to here. If you start getting P2 elevated up to here, that's when we start knowing that even if our ICP is normal, if we go from here to here, that's something that needs to be reported to the surgeon. Because what's happening here is normal. Okay, we got our brain volume, we got our blood volume, we got our cerebrospinal fluid volume, and then we get a lesion, a bleed, or whatever. So pressure's going up, just our volume's going up just a little bit. Pressure's still kind of normal along here, but we're losing any extra space that we have, and so we have no room, no more compliance in there. And so that's where just a little tiny increase in volume starts to skyrocket the ICP. You can go along and your brain can compensate a little bit, and then you push it over the edge and the ICP just goes crazy. So if you go from here to here, even with a normal or maybe slightly increasing ICP, that's when it's time to start getting alarmed. And we need to contact the surgeon about that right away and see if there's anything more that they want to do. Now, if it's Dr. Dirks, he may say, don't wake me up for something like that. Dr. Gans, on the other hand, I think will be very happy that you called him with that observation. Some of the surgical interventions, obviously somebody has an epidural bleed or an acute subdural, they're going to have to go in there and suck it out and stop the bleeding and hopefully solve their problems. So it's not uncommon that you're going to see the surgical decompression. I haven't seen a hemicraniectomy for quite a while. I don't know if our surgeons here do them or just don't. Have you guys seen one? You know what they are?
No place that I worked have I ever seen it.
Really? Okay. We used to.
Of course, I only worked there too, but.
Well, we used to do them, I mean, I wouldn't say frequently, but it wasn't uncommon either over in Spokane. But what they do is they just take a chunk of the skull out, implant it in the abdominal cavity, and then let the brain swell.
Well, see them take just little small flaps, it's not venom.
Right, I mean, it's not, I'm not saying it's a huge chunk, but it's enough to relieve pressure there. And I mean, it's fairly effective. I think we can probably do just about the same job with the ventriculostomy now, because you get rid of CSF and that part of that 80-10-10 equation goes down, and so you have room. So I think that's probably why you don't see it anymore, is because we can do basically the same thing with the ventric by getting rid of the CSF and getting rid of pressure there. I mean, I think we're all familiar with the ventriculostomy. Just the catheter put into the ventricle. The nice thing about a ventriculostomy is that you can drain CSF with it, and it's very accurate. The not so nice thing is it's a great place to get an infection. And so, there's trade-offs. Bolts and fiber optic transducers to the Camino, a little easier to put in. Not so much chance of infection because they're not quite as invasive. But you can't drain CSF with them, and they have a tendency to not be as accurate as a ventriculostomy. Where you may see the bolt or the fiber optic transducer is with somebody that's got such a lot of swelling that they can't even get into the ventricle with the ventriculostomy catheter. So that's one advantage to these. If the brain is so swollen, you don't have to go fishing around in there hoping that you hit the ventricle. pharmacologic, obviously everybody's going to get oxygen, but we want to be kind of careful with that. How many times have you seen just an isolated head injury patient? They're getting 100% O2 and their gas comes back and their CO2 is 37, 35, kind of where we want it, and their O2 is 498. It's like, I'm thinking we're good to turn that down a little bit. The problem with too much oxygen is because what we're dealing with up here in the brain is the inflammatory cascade, and oxygen-free radicals do really bad things in that cascade. And so we want to keep their oxygen normal, but don't hyperoxygenate them necessarily. Vasoactive medications, we talked about those, the pressors that we may need. Sedation and neuromuscular blockers or paralytics. Neurosurgeons just wake up in a cold sweat at the thought of particularly paralytics, but even sedation sometimes. And I understand their concerns. They like to be able to do a good neuro exam, but it's kind of our job within the orders that we have written to balance between being able to do a neuro exam and keeping a patient relaxed enough that their ICP isn't going out the roof. And you know, sometimes we're caught between a rock and a hard place because the surgeons think they're over-sedated. We don't want them climbing out of the bed. So, you know, within the order parameters that we have, or that we can squeeze out of the physicians, we'll give those. Osmotic diuretics, mannitol. Just about everybody gets mannitol, I think particularly Ganse's patients. And you know, we could talk again for 30 minutes on how mannitol works and the things that you need to look for, but some of the big things are just make sure that their serum osmolality doesn't get too high and that they don't get electrolyte imbalances. But just about everybody is going to get that at one point or another. Barbiturates, the phenobarb coma, just completely slows down the metabolic rate and the cerebral blood flow and just kind of mellows the brain out for a few days. Just lets it just mellow out and heal up, hopefully. If we have a closed head injury patient that is awake and is not intubated, has an NG tube, definitely want to give them antiemetics because we don't want them retching and keeping their ICP up with that or increasing it dramatically. Some of the other things that we want to do, really keep stimuli in the room to a bare minimum, keep the lights down, visitors to a minimum. When family comes in, I don't mind having family in with neuro patients, but I try to do a lot of education with them that just being there and a quiet word or two to their family member is okay, but hugging and leaning over the bed and rubbing their back, rubbing their face is not good for them. Any unnecessary stimuli, we need to cut it out. Normal temperature. For every degree temperature that your body temperature goes up, your metabolic rate increases about 10%. So we need to make sure that they don't get a fever. We don't want them shivering either. We don't want them cold, because shivering increases your metabolic rate exponentially. Suction only when necessary, and if you have a patient that you need to suction their ET tube frequently, then if you can, try to combine doing that quickly and suctioning their oral airway quickly at the same time, so you're not constantly doing something that's going to increase their intracranial pressure. Normal blood glucose. You know, again, the brain doesn't have any sugar up there to use. So, you know, it doesn't have any stuff banked up there, so we have to keep it normal. Obviously don't want it low, but we don't want it high either, because if you get it high, that leads to increased fluid in your brain. Your brain tries to suck in that sugar. It's a big molecule, water follows it, and so you have more interstitial fluid in your brain if your blood glucose is too high. And obviously everybody's going to have all the tubes, but particularly an NG or an OG tube, because we don't want them any kind of chance that they're going to try to retch and vomit, because that's going to increase their ICP as well. So, we want to maintain a normal ICP, keep their cerebral perfusion pressure greater than 50 at least, hopefully greater than 60 to 70. And then making sure that we recognize by doing serial exams and are able to describe and tell the doctor what's going on with our patient. That's the most important thing we can do, is making sure that we see something that's going on in front of us. So, it doesn't matter what the change is. If it's a noticeable change, we need to report that to the surgeons. And then they can do with it what they want. It's our job to report it. If they don't want to do anything about it, then that's in their court.
You can't even talk to the doctor at night. You have to go through the Twyla screening process or whatever. It's
But
like
you're reporting it to somebody.
somebody, yeah.
And that's our job. We have to report it to somebody, so.
So are they gonna come up with like a set protocol or whatever for